We'll start with Remimezolam. It's water soluble, ultra short acting, intravenous benzodiazepam. It belongs to the group of benzodiazepam. The pharmacodynamic effect of midazolam and pharmacokinetic properties of remifentanil. So, what are the clinical uses? Procedural sedation like endoscopic procedures, diagnostic and minor surgical procedures. It can be used as a general anesthesia induction agent as well as for maintenance in combination with other agents. It can be used as an intensive care sedation in ICU. And the different salts of remimezolam. There are two salts available. One is remimezolam mesylate and another is remimezolam tosylate. And the chemical structure of mechanism of action are contains the carboxylic ester group present in remifentanil, which is integrated into benzodiazepam 4. Okay. So it enhances the gamma aminobutyric acid GABA type A inhibitory receptor, which increases the frequency of open gated ligand gated chloride channels. So hyperpolarization occurs. That is more of chloride ions will go into the cell, causing increase in the negativity. So there is always all the cells in our body are electronegative inside and electropositive outside. So if you increase the negativity from minus 90 to say minus 130, minus 140, then it will cause more depression. So this is the drug which is metabolized by the inactive metabolite, which is CNH 7054 by carboxylic express 1 located in the liver. And the adverse drug effects are prophylaxis, delayed emergence, and resedation of reversal, flumazenil also. And this is the structure of midazolam. This is the structure of remimezolam. So if you see here, this is the carboxyl group which is attached here. So this is how we must remember that. So this carboxyl group only is, and when it is this carboxyl group is removed by this carboxyl esterases. This is the enzyme which removes the carboxyl group to convert this into the metabolite, which is an inactive product. Can you tell me a drug which whose metabolite will be more active compared to the parent compound?
Morphine, sir.
Morphine or morphine, okay. What about any other drug which is commonly used? Ketamine. Norketamine is also active. Okay. So remember two drugs, morphine and norketamine. Both metabolites are active, but here the broken down or metabolized product is inactive. But this is excreted by the kidney, so this is not. That is the reason why it is not applicable. So even though it is not active, we don't want to take any risk. That is the reason why it is contraindicated. It has a relatively high clearance with a small steady state of volume of distribution, short elimination half-life, and short contact sensitivity half-life. What is the definition of short contact sensitivity half-life?
Sir, after stopping the infusion, how long it will take for the 50% of drug to metabolize this contact sensitive half-life, sir?
The fall in serum plasma level to 50%, not metabolize, but it is to say that the time taken for the serum concentration to fall by 50% after stopping the infusion. So shorter the duration, faster the recovery, longer the duration, slower the recovery. So some drugs have variable action depending upon the dose and duration. For example, propofol, does it have a constant half-life? Contact sensitive half-life or different based on the infusion if you use it as an ICU sedation.
Propofol, sir?
Propofol. It will have different time. No?
Yes,
For
sir.
6 hours you have particular time, then 10 hours.
6 hours, 90 minutes and something.
So longer the duration, it takes longer time to come out. So you have to stop the drug well in advance if you plan to recover the patient early. Whenever you use it for total intravenous anesthesia, you must plan to stop the infusion well in advance if you want to get a patient out on the table alert. So it is rapidly and extensively metabolized by tissue esterases, that is carboxyl esterase is the enzyme, and it is converted to, and this metabolic product is excreted into the urine. And it has a protein binding also. 92% of it is bound to serum albumin as soon as you inject it intravenously. The offset is faster than midazolam, but it is similar to propofol. So when you use it in the intravenous infusion, it is much faster recovery because midazolam takes a longer time if you use it as an intravenous infusion. And it is really independent of the infusion duration. Unlike what I told, propofol, depending upon the duration, the half-life will go on to increase it. Whereas for remimezolam, despite the number of hours of infusion, the contact sensitivity time is the same. So it will recover within a few minutes of stopping the infusion, despite the number of hours of infusion. And it can be used as a 5 milligram dose over 1 minute for induction during procedural sedation, and it can be used as a IV supplementation 2.5 milligram over 10 minutes, and then with 2 minutes the gap between the doses is required. And if you want to use it as a TIVA, you have to use it at 6 to 12 milligram per kg as an IV infusion for induction. Then to maintain, you use it at 1 milligram per kg per hour. And this is the commercial name for that. It is Bifova, and it is available as a 20 milligram vial. It is a powder which has to be reconstituted. Okay? So it is presented as a 20 milligram powder which is reconstituted with 0.9% sodium chloride, and the intravenous dose followed by an infusion if necessary. You can use. These are all the components of that. So when you reconstitute it with 8.2 ml of 0.9% solution for saline, then each ml will contain 2.5 milligram of remimezolam, which is equivalent to 3.4 of the remimezolam distillate powder, and it has 10 milligrams of dextran 40 and 6.7 milligrams of lactose monohydrate, which is a bulking agent, and the pH is adjusted to with hydrochloride or sodium hydroxide to make it adjustable pH. And you have to discard when unused portion after 8 hours because it doesn't have a bacteriostatic agent. So just like propofol, it has to be discarded if you are not using it after 8 hours. And soluble in slightly acidic environments, and it can precipitate with linear lactated or acetate solutions such as ringer lactate or plasmalite. Now coming to Sugammadex, it's a modified cyclodextrin mechanism action, selective relaxant binding agent for reversal of mainly aminosteroidal non-depolarizing or neuromuscular blocking drugs like rocuronium. This is mainly prepared for rocuronium, but now used liberally for rocuronium reversal also. And the earlier drug pancuronium also can be reversed with that, but pancuronium is hardly used or never used nowadays. So books don't give the dosage that is required for reversing pancuronium, and I don't think anybody uses pancuronium nowadays. But the three drugs that can be reversed are rocuronium, epironium, and pancuronium, which all belong to this particular group called aminosteroid non-depolarizing muscle relaxant. And gamma cyclodextrin is it is something like a donut. All of you would have eaten or seen a donut. It's a circular thing with a central hole. So the outside is hydrophilic. It is repellent to water, whereas the interior is hydrophobic pore that traps the aminosteroid ring. And the complex is pH and temperature independent and very stable. That is, once the when you inject a non-depolarizing muscle relaxant, what will happen? Not all the drug will go to the neuromuscular junction and bind and block the neuromuscular transmission, because we inject more than what is required to block the neuromuscular junction. So there will be some free drug circulating in the plasma, and if the body is able to metabolize the drug by enzymatic activity, then the circulating free drug will go and occupy and try to continue the blockade for some more time. But once the concentration in the plasma drops down, patient will start because the competition is it is mainly a competitive blockade between the acetylcholine, which is a normal transmitter, and the non-blocking drug. So what will happen? If the acetylcholine production exceeds the number of molecules of the normal non-depotential muscle relaxant available, then it will displace the drug and it will occupy and establish the normal transmission. So here what happens in the Sugammadex, it first traps all the free circulating plasma drug, so that there is a concentration gradient difference between the neuromuscular junction drug, which is blocking already this receptor, and the plasma level. And so what happens, it draws out the drug which is attached to the acetylcholine receptors at the neuromuscular junction. So the mechanism is first to capture all the unused drug circulating in the plasma, create a gradient between the drugs molecules that are attached to the neuromuscular junction, and then draw them out, and then trap them also and eliminate them. That is the mechanism by which it acts. So it encapsulates the circulating amino steroid first. That is the first step, rendering them inactive, and then this removal of the circulating free drug promotes the dissociation of the amino steroid from the neuromuscular junction by creating a concentration gradient between the neuromuscular junction and the plasma. And once the drug comes out of the neuromuscular junction, that will also be encapsulated and made inactive. So this picture will nicely tell you, taken from the World Federation of Society of Anesthesia editorial of the week. There is a beautiful article on that. So this is the rocuronium molecule, and this is the Sugammadex, like a donut with a central hollow thing. So what happens is it captures the rocuronium and keeps it in the center. The exterior is hydrophilic, the interior is hydrophobic. So once it goes into the center, it cannot come out. So it forms this complex, and this complex will be eliminated by the kidney. Now coming to the pharmacokinetics, it has to be given IV and distribution. It has less than 1% protein binding. The volume of distribution at a steady state is 18 liters, and metabolism doesn't get metabolized immediately. And the elimination by renal route, half time is 100 minutes, half life is 100 minutes, and plasma clearance is 120 ml per minute. So administration alters the pharmacokinetics of rocuronium. Normally, if rocuronium has to be eliminated on its own, it takes place via the liver. So it alters the pharmacokinetics of rocuronium. The rocuronium complex behaves similar to Sugammadex. So elimination of rocuronium shifted away from the biliary system or the renal liver to predominantly renal excretion. So the individual rocuronium molecules which still circulate to some extent in the blood plasma will be removed by the liver. Once the rocuronium is encapsulated and forms a complex with Sugammadex, that has to be eliminated by the kidney. So that is another important point that has to be mentioned. The dose is guided by the degree of neuromuscular blockade, and no published dose for pancuronium, and of course it is not used also now. Onset is slower for vecuronium than rocuronium. So when you use it for reversing vecuronium after your usage in surgical patients, the reversal is not that fast like happening after rocuronium. And for shallow block, where the train of 4 is 2 milligram per kg, deep block, when the post-technique count, it is just 1 to 2, it is 4 milligram, and immediate rescue reversal after the use of rocuronium for emergency rapid sequence induction, it is 16 milligram. And the adverse effects can produce hypotension, cough, altered taste, dysphagia, and hypersensitivity to reactions. Presentation, it is available in 200 milligram and 500 milligram, and clear colorless solution. Photosensitivity must be stored in protected ambient light, and shelf life is 3 years. It can be stored for and Brindon, Bridion. Now neon also has come out with that with a different name. This is a first brand that has to be coming in. And this is the neon, you have 50 milligram, but this original one was 100 milligram per ml. And this is the questions I made it for the OSCE. So I'll just go through that. Category of diet is a cyclodextrin gamma compound. Mode of action is it's like a large donut-shaped molecule. It has a lipophilic core and a hydrophilic periphery, and it encapsulates rocuronium molecule by diffusing out from the neuromuscular junction. And it is mainly used for rocuronium reversal, both in children and adults. And it has no interaction with acetylcholinesterase. There is no need to give glycopyrrolate or atropine. And which other muscle relaxant can be reversed is vecuronium and pancuronium. What is the dose? Of course, this is a common question that examiners will ask you. So 2, 4, 16, the magic word number you have to remember. The side effects are vomiting, diarrhea, tachycardia, dizziness, altered taste, etc. The Levosimendon is a calcium sensitizer and inotrope and an inodilator. So it is called because it improves the cardiac contractility, it's an inotropic agent. Because it causes vasodilatation, it is also called a dilator. So it is an inodilator. It is a pyridazinone dinitrile derivative molecule. This is the chemical name for the drug, pyridazinone dinitrile derivative. And the mechanism of action, it sensitizes the cardiac muscle to calcium, stabilizes the troponin C in a conformation that triggers and maintains circulation. So, what are the 3 troponins that we have in the cardiac musculature? Damodara.
Sir, tropi,
Troponin C.
And troponin T. Okay. What is the
troponin T,
function
yes,
of
sir.
each? C is for contraction. Okay, so once the calcium goes and attaches to the troponin C, this troponin C causes the actin and myosin to come closer to each other, and troponin I is the one which has to inhibit this activity. So that I stands for inhibition. So that only breaks down. So once the contraction goes in, it has to relax it afterwards. Otherwise, it will be always contracted. Like what happens in your malignant hypertension. Because what is the mechanism of muscle rigidity in malignant hypertension? MH.
Mechanism of action of
Malignant hypertension. Mechanism or
it
pathophysiology.
irreversibly binds to the receptors, so it prolongedly activates. It leads to
No, calcium will stimulate the attachment of troponin C to the actin myosin complex and bring them together to cause the contraction. Okay, that is the role of calcium. What happens in malignant hyperthermia? Why the muscle goes into rigidity? What is the basic pathology in that? Which particular thing is mutated? Which intracellular?
So binds to the ryanodine receptors, sir.
The ryanodine receptors, which are just nothing but the guarding or gate for the sarcoplasmic reticulum. Okay, they are supposed to release the calcium. The sarcoplasmic reticulum will release the calcium, which will travel to attach itself to the troponin C and cause the actin myosin complex to contract. The troponin I will inhibit and release the calcium binding, and the calcium will be retaken by the sarcoplasmic reticulum. Okay, so this is how the actin myosin complex activity goes on. What happens in malignant hyperthermia is this ryanodine receptor, which is supposed to automatically close to prevent the calcium leakage into the cytoplasm, remains open for a longer time once the stimulus comes. So calcium keeps on pouring out of the sarcoplasmic reticulum, stimulating all the troponin C continuously without allowing the troponin I to inhibit that, and that is how the whole mechanism of rigidity, heat production, and temperature rise, all these things happen. Okay? So that it does not impair the diastolic relaxation. It also produces vasodilation, but the mechanism there is it causes the ATP sensitive channels to open and cause the vascular smooth muscle relaxation. And it reduces preload, afterload, and improves oxygen supply. This picture will tell you about the actin myosin complex being there, and this is the troponin T which stabilizes the thing, and troponin I which is there for inhibiting the contraction, and troponin C which has to go and stimulate this actin myosin complex, the thin filament and thick filaments to come together. That is, this is the normal passage. So once Levosimendon is given, it will go and occupy here. It will cause the troponin myosin complex to form, and that will also enhance this contractility. So this troponin C is very, very important for a normal good contraction of the actin myosin complex. So that is facilitated by this Levosimendon by attaching to this position and improving the activity of the troponin C. But it doesn't cause continuous contraction like in malignant hyperthermia. But enhances the activity of tropomyosin because the muscle is already not contracting properly because of the ineffective actin myosin complex activity. So in such weak muscles, cardiac muscles, this enhancement of troponin C action will enhance the contractility and produce a good cardiac output. So it increases the contraction, stroke volume, and coronary blood flow also is improved, and it decreases the SPR by the decrease in vasodilation that is produced, and decreases the systolic blood pressure also, and decreases the pulmonary capillary vein pressure, pulmonary artery pressure, coronary vascular resistance, and decreases the myocardial oxygen consumption also, even though it causes contraction of the actin myosin to improve the contractility. It causes because the coronary vascular resistance is decreased, coronary blood flow is increased, so there is no increased demand on the oxygen consumption. And it shows improved symptoms in patient symptoms of like breathlessness and pulmonary edema, all these things come down. There is a reduction in BNP, which is a marker of your cardiac failure, brain natriuretic peptide, and also total survival is not very great with this. That is why this drug is not very commonly used, and it can be used with beta blockers. Does not compete with the Levosimendon, and it has an anti-inflammatory and anti-apoptotic effect also, and it has a weak cyclic KNP and PD inhibitory effect also, just like your phosphodiesterase inhibitor milrinone, which is used also in conjunction with that. This also has a very mild inhibitory effect. In pharmacokinetics, absorption is either, it can be given per oral also, but commonly used only as a IV drug. And distribution, it is highly protein bound, peak concentration reached after 2 days of treatment. And metabolism, it is by metabolic hepatic enzymes, and it has an half-life of 70 hours. And elimination after dose adjustment in renal insufficiency, requires dose adjustment in renal insufficiency, because it's eliminated in urine and as well as feces if it is given orally. And indications, heart failure, both acute and chronic, can be used in sepsis, post-resuscitation myocardial dysfunction, and perioperative optimization of cardiac patients with cardiomyopathy. So it increases the ejection fraction, decreased left ventricular filling pressure. So this is the mode of calcium sensitization, and it can cause hyperpolarization. So lower the pre and after load anti-ischemic effect, and it can protect cardioprotective effect and anti-ischemic effect because it protects the mitochondria from ischemia. And this is the active metabolites. Both the parent compound and metabolite, which is given only a number now, also active. So they can cause inotropy, vasodilation, and cardioprotection because of the protection of mitochondria in the cardiac cells. And the dose, it is a loading dose of 6 to 12 microgram over 10 minutes. And it is we used because just to have a continuous effect, we have to use it as a infusion of 0.5 to 0.2 microgram per minute. Adverse effects, it can, because of the vasodilatation, it can produce hypotension, headache, and dysrhythmias. And this is the 12.5 milligram presentation. It's a lipofilase powder which has to be again reconstituted just like your Remimezolam. And there is a 2.5 milligram per ml dosage is also available. The brand name of Simdax. Levosimendon, Levosimendon. So two presentations are available. Okay. That's about the three drugs.